All right. Well, I'd like to welcome you to today's special edition of Duke Margolis seminar on the Capital Impact Council on advancing private investment that improves healthcare and health. We're really glad to have you with us. This is a good opportunity to learn about the CIC. It's an initiative that Duke Margolis started in partnership with a uh, group of investors who are committed to the goal outlined here on the title side, how to advance private investments that improve healthcare and health in measurable and important dimensions alongside generating financial returns. This is an important part of healthcare and the efforts underway to transform the healthcare system, which we want to be for the better. And so today we're going to hear from several CIC members, experts who are working at the intersection of healthcare and business and evaluating the impacts of innovations in care with a practical focus of how we can make this more routine and meaningful in real through real world case examples. Next slide, and I'd also like to introduce, I'm going to turn to her in just a minute, my co-chair for the Capital Impact Council, Dr. Cheryl Pegas. It's very quickly, first though, reminder that Duke Margolis is part of Duke University, has a strong tradition and policies related to academic independence. We do not take political positions or do advocacy. We want to make sure that everybody in and out of our projects and our events are free to speak their mind regarding important issues. Additional details are in Duke's policy guidance on these practices. And next step, is our agenda for today. We're going to start out with an overview of what is the Capital Impact Council, why is it doing what it's doing, and why are we focusing so much on this issue of health value evidence quality generated in real world settings that is applicable to helping assure that we get value alongside financial returns in private investment activities. We're then going to provide some examples from this newly released health value evidence quality framework that illustrate how it can and is being applied, and have some discussion about what the implications are and potentially how it can be done better. And then we're going to turn to a panel that focuses on that topic, how to apply, make more routine, easier to do health value evidence development, high health value evidence quality alongside private investment activities more generally that impacts healthcare. We're going to have some time for questions and comments at the end. We have, I think, chat or sorry, a Q&A function going. So please feel free to enter questions in any time. We'll try to work that into the discussion and then have some Q&A time towards the end of this webinar. Thanks again for all of you joining us. And special thanks to Dr. Cheryl Pegas, who's co-chair of the CIC and currently the CEO and chairman of Flight Health. Cheryl, thanks for this partnership and for being with us today.
Thank you. Great to have everyone with us today. We have hopefully some really great materials to share with you. Mark and I really want to open this up for discussion, share our learnings and our process and our why of how we started this, which I think was one weekend just chatting about how do we ensure great investments in healthcare continue and the progress we've made to date. And we hope that with you, a lot of great progress going forward. My section is really telling you how we got here. So we'll go straight to that. Why? I think all of us here could say, we would all love to see better healthcare delivery models in rural parts of the country or in underserved communities. As we look at AI and what's available, we'd love to understand not just how those models are being built, but how are we looking at them for guidelines? If you're in a health system, you'd love to improve the efficiency and delivery of care and the satisfaction of your patients. When you look at everything that I just mentioned, and there's lots more, how do you fund it? How do you ensure that you're innovating and taking advantage of, be it new science, new technological advancement, new policies? while running your existing business. In many areas, the way we do that is through private investments. Private investments offer the opportunity to run the day to day and to innovate in parallel, particularly to have it funded by like minded individuals. We're all aware that there have been many stories about how private investment has worked or not worked. The goal for us in forming the Capital Impact Council is to always focus on how do we make it work better. And that is what we are trying to do. You'll hear from some of my incredible colleagues who, even before we started the Capital Impact Council, and even with many of the stories you've read of where investments have not worked well, have always formed their own organizations to focus on what we call health value. They, yes, want to be sustainable, so achieving financial returns, but alongside, they've always focused on building offerings that look at affordability, access, and outcomes. More importantly, they've always measured them. And you'll hear some of that today. This is not just how investors look at it, though we believe they are the linchpin for what's above them and what's below them. If you're a limited partner and you're looking to invest, you want to know, are the people I'm partnering with doing things to improve health value? And so we believe the value to LPs is as important as it is to entrepreneurs who usually are quite mission driven in how they're building out new offerings. So our focus on the investors is really to touch all parts of healthcare. And, Duke Margolis, why with Duke Margolis? It's because we really want that independent thinking and data analytics that will come from this policy group, but also the ability to transparently have data reviewed. So, data analytical tools, these are things that we've brought in to these incredible investors. Some already had them. And what our hope is by making this public is that we can help not just our members, but really change how we all look at measuring outcomes going forward. We were established in 2024. I always, when I look at this, I smile. Of the few people we called and said, hey, we want to do this. Will you join with us in helping us to launch this? And then will you be transparent in sharing data? More importantly, will you bring like-minded individuals with you? And you'll see some of our members in a second, but no one said no. Everyone wants to, I think, do the right things in healthcare to impact cost, outcomes, and also reach all of our populations. These are talented and experienced investors, some clinical, some non-clinical, but they've worked in team-based environments where they're bringing the best expertise together to ensure that we're getting the best outcomes that we can. So positive impact on healthcare outcomes, access and affordability alongside financial returns. This is our mission, and driving the impact of private investments to enable us doing that. We hope that we not only do it, as I mentioned, for us, but that we're able to share it across our members' portfolio of companies, but for others who want to also show that they have always impacted positive outcomes, or frankly, are learning how to do that. These are our members. I will start on the right with Bob Margolis, who said to us, this might be difficult to do. Let's see how quickly we can run. And Bob, if you're on the call, we've run pretty fast. This is just 1 year of work that I'm sharing with you. Those who joined us in the beginning, David Brailer, one of my mentors, Ken Bach, Mark Samuels, and then this incredible Duke Margolis Institute support staff. I would say we were building and flying the plane, and Audrey, Katie, Eddie, Frank, Luke, and Patty were there every day to remind us of the timelines and deliverables. Can't thank them enough for the work that they've done. You will hear from some of our CIC members. We've continued to add additional members we'll talk about that a little bit later. But this group of members have participated in everything from reviewing the information, providing feedback, writing the content. And so you've got a really, I'd say, engaged group of early founding members. And just on behalf of Mark and I, thank you so much for the work that we've asked you to do as an additional job that you've all done. It has brought us, I think, to where we are today. And like I said, you'll hear from some of our members a little bit later on this call. So we talked about that weekend call in 2024. Fast forward to 2025. We not only developed a health value ROI framework, we actually launched it and made sure we were in an auditorium where we said to everyone, now say with us HVROI. We're hoping that that becomes a thing. But we really said, there's always been financial value, but no one's really focused on, am I also building it simultaneously to have a health value framework? And that's what we built and rolled out. Mark and I presented this at ACHE last year. We actually also did some press. We had Fierce Health launch this. And what you should know is as we did that, the pickup, I think we were a bit overwhelmed with. We expected that there would be interest, but we did not know, I think, maybe the opportunities that everyone was looking for. And I think because it is Duke Margolis Institute, the credibility that was added to this work. So again, the team that's been building this have really added, I think, significant value. We then went ahead and launched our HVROI framework, and you may have seen us at the Health Evolution Summit, the Duke Margolis Annual Conference, the HICPE Forum. We've done the Health Conference, we've done podcasts, we've done writings, and that has allowed, I think, many people to learn about us, such that we've added new members. You hear us talk about rolling out new tiers within the organization where you may not want to be a member, but you really want to have access to some of the expertise. And so we'll talk about that a little bit more. And then we continue to refine the work that we're doing. More importantly, the way you do this is you build a framework and then you test it to see if it truly applies. And that's what we've been doing with our members and their portfolio companies, really ensuring that it is a framework that is usable. We looked at a lot of existing frameworks, and then what we wanted to do is say, what should we add into those frameworks? What should we ensure that investors can utilize? And how do we scale this in a manner that an entrepreneur who's looking at where should I go and partner with a private equity VC group strategic partner, where did they have clear enough guardrails that I know what is expected, but more importantly, that I know the value that we would deliver. And so this is our framework. I mentioned already healthcare entrepreneurs, the value we believe that we're adding there, how private investors work. We develop not the health value ROI analysis. Many investors already have a financial ROI analysis. What's really interesting here is many of those analyses already include how does it become accessible? How do we scale? How do we ensure that reimbursement is occurring? With the end goal for all of us showing how we're improving outcomes in individual communities, because communities are different. How are we addressing areas that still have gaps? Behavioral health is one we'll talk about. We all talk about cardiometabolic care, but we also all looked at how are we ensuring that the people who will look at this are able to look at a model transparently and say, we understand how we got here and we understand what was utilized. We have two pieces that we look at this, our model and the evidence. And what we do is we look at published peer-reviewed literature to ensure that we're taking in guidelines, not just on clinical disease states, but on frameworks that have been used with other organizations so that we're building upon, not attempting to say this is brand new, but saying how do we utilize it in the investor community, and then look at KPIs that you would normally do, but look at these in a health value model. Did we achieve the outcomes for the populations that we said we would? Did we achieve the accessibility that we said we would? So alongside your financial ROI, having your health value ROI. I know Katie is telling you links of where you can see some of this information. So please go ahead and check on those. I'm going to read through some of these. These are some of the initial case examples. You'll hear even more today. And then we've posted a number of these publicly. Obviously, American Heart Association Ventures is a member. Seven Wire is a member. Echo Health Ventures, Healthier Capital, and Temasek. These are some of their companies. And I really wanted to highlight the number of available data that's there because many investors are already doing this. Many investors are already collecting this data, sharing it. Frankly, it's how they might go out to raise funds for like-minded LPs. And so really ensuring that you hear from us that this is work that we're building upon. We didn't start it. Our goal is to have really great inputs with the guidelines, utilize the expertise from Duke Margolis, and help investors who are already on this path not only run faster, but scale it in a way that we can demonstrate this on a national level. Earlier this year, we worked on how do we enhance what we've already built. And we did that in a number of different ways. We took all of the existing frameworks that existed, and you may think of Nesta as a framework. Some of you may remember some of the frameworks that was being built out for value-based care. We literally looked at all of the frameworks that were publicly available and really started saying, now that we know how we should look at not just the input data that should be collected, and we now know some really good frameworks that have been developed, how do we tailor it to our target audience, which are investors? And that's what you will see from us today. And so we have now launched that, we hope, in a way that allows it to be accessible, allows organizations to take it back in and utilize it within their own organization, but more importantly, also give an easy button. You're seeing some of the comments that we have made publicly about this, but this is really a commitment. This is not this is a great project. How do we improve healthcare and fund it for all of the needs that we have today? We see it as an opportunity. I think opportunities work the best when you've got many people utilizing it across many different organizations, and then doing the really important work on the other end, which is analyzing that data so we can iterate in a manner that brings out the best practices. That's what we hope we're doing at the Capital Impact Council. So I'm going to give credit where credit's due. Lisa Suennen developed the wave that you're looking at here. And I will just at a high level say, why does this exist? It's because companies are at different stages. There are companies who are just getting started. If you don't have enough patients on your platform, then you definitely don't have enough data. But how do you then utilize a health value ROI program? Well, you assess what guidelines you should be using as you build out an offering. You assess what data you should be collecting, all the way through to a stage 4 assessment, which really looks at you've actually had enough time to be in market. You've collected enough data. Here are ways that that should be analyzed, both clinically, both outcomes driven, as well as financial. And so we've really developed this wave to be utilized across very early stage companies to late stage companies. You'll hear about some of that today. I've given credit for the design and for this content I'd say every member, every CIC member contributed because they're each bringing their own experience and expertise, but they're also telling us, here's how we will go back and utilize it within our own organizations. So do want to recognize the entire group for having put this together. And we've looked at what does stage one look like, right? You've got evidence then. Okay, how do we ensure that you've implemented that? What are the metrics that you're using as you look to stage two? We think a really easy way to look at how everyone who's an investor can look across their portfolio and participate, and then partner with entrepreneurs. Obviously, the best is at the beginning when you're launching an offering versus, when you've had everything launched, now you're asking everyone to go build the framework to collect data. And so we hope this is useful, not just for our members, but we hope we are sharing this with everyone so that you can utilize it within your own organizations. How's that for timing? Thank you, everyone. Thank you for the comments as
Mhm.
well. I'll take an opportunity to read those as Mark introduces the next section.
Yeah, thanks, Cheryl, very much for presenting a lot of information and linking to a lot of the prior work of this group over the past year plus, which is on our website. For those of you who are interested in more details on case examples and the underlying frameworks that Cheryl described, both for thinking about health value in the relevant context for a particular kind of investment in healthcare, and for generating the evidence behind it at each stage in a company's development, please look at those. But we think a good way of illustrating this approach is through actual case examples. So I'm going to turn to that now, including to a case example that Cheryl's company has provided. You saw the four stages of health value evidence quality, which can start out with just getting some empirical proof points for a logic model for health value and potential undesirable consequences to guard against, taking that all the way through, more revised and more comprehensive to the stage of independent, well-designed, published evaluations. So we're going to go through some of those examples right now, and I want to thank our CIC members who put the work in to put these together and are going to share some of these experiences today. As Cheryl mentioned, we have 11 cases initially, case examples of applying the evidence quality framework on our website. Um, these are, and we'll be talking about four examples of those now. Those come from both the earlier stages. Amir Don Rubin from Healthier Capital is going to talk about AME Health. We'll hear also from Suzanne McLemore with Echo Health and Echo Health Venture and their work with a company called Strive Health. Back to Cheryl to talk about flight health, and finally, at the more advanced stage of investment, Alex Albert from TPG discussing Food Smart. That's a subset of the examples we have already. As Cheryl mentioned, we are hoping to see this approach grow and are looking for more partners willing to apply and help improve the framework. What we've learned so far, I'm not going to go through all of these in detail. We are learning from case examples since, frankly, this kind of relatively comprehensive framework development and application hasn't yet happened widely in this space. And I appreciate some of the comments in the chat from Art Kellerman and others. We have tried very much to build, as Cheryl said, on previous learnings, but focusing really on these issues from an investor perspective. What are the best practices for investors to apply in their frameworks? We found that this approach is feasible, especially if it is an intentional focus at every stage of the development of a company and every stage of investment, to go from early exploratory Series A to gathering more certainty about how exactly the business model can work to deliver on the goals. Those goals get revised and the business model get revised as you go along. But by the time you're scaling, I have more confidence confidence based on more solid analyses of data internally. And then, as I said, eventually getting to independent evaluations that have credibility or publishable and can be shared transparently with the public. We've seen different ways in which the relevant value framework and value measures based on that framework are applied in different types of investments. We're going to see a range of those applications today. We're looking for, again, ways to broaden this framework in the future and refine it. And we'll get to some learnings early along the way of steps that make it easier and can make it more routine to generate the effective evidence at each stage of a company's development. So if we go to the next slide. Um, we're gonna turn to our investor leaders to talk about their application, their contribution to developing the framework, and then applying it in their particular context. I'm going to start with Amir. So, can I turn to you to talk about your earlier stage application of this framework?
Absolutely. Mark, thank you so much. And Cheryl, thank you so much. What a delight to be here with everybody on this Zoomcast. Hi, I'm Amir Dan Rubin. I'm the founder and managing partner of Healthier Capital. We're an early stage health tech venture firm, and our mission is to deliver healthier outcomes for all. And how do we know how to deliver healthier outcomes for all? As Cheryl said, it's through the HVROI. Now we have a framework that we can think about what healthier outcomes look like. I have the privilege of serving on the Duke Margolis Institute for Health Policy Advisory Board and also on the Capital Impact Council. And I'd like to take just a couple of minutes to share with you a little bit about Amai Health and how we've used the HVROI model here. Amai is a technology powered serious mental illness model of care. It combines physical clinics and digital health to care for patients with schizophrenia and psychosis. There's about 15 million patients, adults, people living with severe mental illness in the US, and they have a 10 to 20 year shorter life expectancy than the general population and are associated with roughly 300 billion in annual economic costs. And what Amai does is it takes these patients who are admitted to the hospital post discharge and puts them in a complex care medical home, which combines psychiatrists, psychologists, long acting injectable meds, primary care, peer support, and manages these patients longitudinally. Maybe if we turn to the next slide, we'll turn to a little bit about some of the outcomes. So some of the key results, if you look at the standard of care in the population, about 23%, close to 1 in 4 of these patients, when they're discharged from the hospital, get readmitted within 30 days. Hospital admissions can cost thousands, if not tens of thousands of dollars. Amai, which has been up and running now for a few years and has multiple locations in a few states, cumulatively is running 3.4% 30-day readmissions. And we also see very high compliance in patients completing their lab screenings, routinely taking their medications, and following up post-discharge. And we're also seeing patients have a higher retention rate. And if you're a patient here, this can lead to much better outcomes, improvement in validated measures of anxiety, stress, depression, and psychosis using validated tools. If you're and we also show very high satisfaction, 91 net promoter scores, so very, very high satisfaction rates. And for those paying for care, we see tremendous savings. Actually, if you go back one slide for me, please. On the bottom, the cost impact, overall, only 9% of patients in 2025 were rehospitalized through their time at Amai, relative to a 33% annual rehospitalization rate. And so that is that reduction in admissions and ER visits is about $22,000 saved for a payer. The other interesting thing, too, is this is in-year savings for a plan, largely because the 30-day readmission rate is so high. So just as a model, health plans like it because they don't have to wait multiple years to see their return. And maybe if we flip ahead 2 slides to the final slide here, just a little bit more about some of the methods. So this Amai Health is a reasonably Series A, B early stage company, but is already at a stage 2 on the health value evidence quality level. So they're using validated clinical instruments like the CAT-MA, HPA-Q9, and GAD-7 for outcomes and symptoms. They're using financial measures. They're using net promoter scores, and they're comparing the results to published standard results and surveys. They are also comparing themselves to themselves on trended results. So hopefully this gives you a flavor of an early stage company using the HV ROI model. Mark, I'll turn it back to you.
Great, Amir. Thanks for that concise presentation of a lot of work going on at the early stage. We're going to progressively, as you'll see, move to more further along companies that have had more time and experience to test out, validate their model, and get to additional evidence development. But Amir, thanks for that example of how this can be done even at the earliest stages by looking at the literature and tracking metrics that reflect the logic model for the benefits and potential watchouts for dealing with such a important and often underserved complex population. I'd like to turn now to Suzanne to talk about her experience, Echo Health's experience as investors behind Strive Health.
Yeah, thank you, Mark. My name is Suzanne McLaurin, and I'm with Echo Health Ventures. Echo Health is a corporate venture capital organization founded in 2016. And today we invest on behalf of 4 Blues plans. Those include Cambia Health Solutions, Blue Cross North Carolina, Blue Cross Blue Shield of Tennessee, and Arkansas Blue Cross Blue Shield. And since our founding, Echo's always had a dual mandate, which fits quite well with the work of Margolis and the Capital Impact Council, in that we seek financial returns as well as strategic engagement leading to positive outcomes in the healthcare ecosystem. So it's really important for us to see healthcare transformation through our investing, and it's been part of our DNA since we started. And we spend a lot of time with our portfolio companies and the plans that we serve to engage in that hard work of how do you build partnerships to lead to those types of outcomes. So today we're sharing some work that Strive, one of our portfolio companies, has really put a lot of work into building, and also exemplifies some of the work they're doing with the plans that we serve. And let me just spend a minute on why this market was important to us and why we started to look at Strive, because starting back in 2018 and 2019, our health plans were looking for a way to disrupt and transform the kidney care market. Today, and you'll see this in some of the use case, there's 145 billion spent annually in this market. It covers 37 million patients, and many of those patients don't know they have the disease, which often results in poor care, very expensive care, and just a very poor member experience. So the health plans were looking for something different, and I heard Cheryl mention these words in the beginning. They wanted this market to work better. How can we find better care and more affordable options for our members? And we invested in Strive in 2019, really at an early time where they didn't have a lot of proof points yet. They were very early in their journey. And you'll see today that over the last couple of years, they've been able to improve this market significantly. And I'll take you through some of those. Strive spends a lot of time on chronic kidney disease, really how they can care better for people and slow the progression of the disease and keep them better managed. And so, as I mentioned, when we were looking at this, we were highly interested in this big population that had high expense and really poor outcomes. And we wanted to improve both the patient and payer impacts. So looking at affordability, quality, access, and experience. And if we look at some of the results that are in the STRIVE case study, I'll call a few out. Because they identify patients earlier and because they practice this whole person care model, they're actually able to reduce emergency department admissions, often shorten those hospital stays, and reduce hospital readmissions over 30%, close to 37%. And ultimately, that leads up to a 20% reduction in total cost of care. And that is a huge reduction in a very large market. And we're seeing those same results at the Blues plans that Strive works for. And the other piece that I mentioned, which was very important to us and Strive and the plans, was increasing quality. And they'll note a 67% increase in optimal dialysis starts. What that really means is that patients are better managed and better treated, allowing them to get the right care at the right time and stay out of the emergency room. And finally, the other lever that was important to us and very important to patients in this model is how do you make the member experience better? And they're seeing a 94% net promoter score. So people who are within the STRIVE system are seeing better results and really want to track those on an ongoing basis of their experience just being more powerful. So I think it's a great example of partnership, how the portfolio companies that folks invest in with health plans and with the broader healthcare ecosystem can look to improve impact and outcomes. And we appreciate working with Margolis and the Capital Impact Council to help us shine a light on this. And thank you to Strive for the hard work they've done here.
Suzanne, thank you and Strive, and highlighted, as we mentioned in that more detailed report on evidence quality that we released. Strive is a good example of taking advantage of an approach that EcoHealth has applied of building in an ongoing kind of platform relationship with a range of the potential customers for these activities to make it easier to do this real world testing for the cost, quality, access measure impacts that Suzanne was describing. So now we're going to move to our next case example as we get companies that are a bit further along and have done more in the way of independent evaluations. I'm going to turn back to Cheryl to talk about the Flight Health experience with developing evidence on health value.
Thank you, Mark and Suzanne. Wonderful to see Strive and Amir, of course. Amir's work is just pretty incredible. Again, addressing true gaps that we have today. Flight Health is an earlier stage company, but we've really invested in generating evidence. Speaks a little bit to the founders being clinicians and very much focused on evidence, even as we were building out a business model. I'll say this because I think everyone may have heard the term cardiometabolic. In 2023, the American Heart Association coined the term cardio-kidney metabolic only because we were seeing, obviously, the direct links from obesity to pre-diabetes to renal and cardiovascular disease. And so it's only been a term coined in 2023, but with a lot of good evidence-based literature. Flight Health started actually before that with a focus mainly on looking at obesity and prediabetes. A couple of years ago, we began doing cardio-kidney metabolic in 2024. And one of the main reasons for that, and this is just, kind of how do you use the science to build your company? About 90% of the US population have an early stage cardio-kidney metabolic condition. So really important for us to think about that. For a lot of these conditions, I mentioned hypertension, and I'll include hypolipidemia. We actually have really good treatments. We have evidence-based treatments. We have good outcomes data. And so how do you take all of that literature and build out a program to really help us achieve the outcomes that we should? There have been some questions about outcomes. So outcomes are access. It's taking into account the cost for a patient so that they can sustain and have great adherence. But it's also looking at how do clinicians easily provide the best care of what they get up every day to do without feeling burnout or a lot of strain in delivering that care. So when you think of flight health, we're thinking not just of cost, what the patient needs, but how are we helping our healthcare professionals enjoy this work and do it well? These are some of our results. As I mentioned, the company's been around for quite some time, and these are published results independently obtained. Really great weight loss at 12 months, reductions in hemoglobin A1C. You're seeing reductions in blood glucose. More importantly, is we're using the entire armamentarium of treatment for cardiokidney metabolic diseases. We're using statins and blood pressure meds, which are all, as many of you know, generic. And we're also using a lot of the non-GLP-1 drugs to achieve these results, ensuring that we follow evidence-based guidelines. So we're giving patients the treatments that they need across the continuum. And those who have the most comorbid conditions we're seeing have our highest GLP-1 utilization. The key here, as you look at this data, as you know, it's not whether we can tell patients they have a condition, it's whether we can help them and support them in being able to take treatment over 12 months, over 18 months. And what we're really proud of is our adherence, 86% at 12 months, 76% adherence at 18 months. Most of our customers have multi-year contracts with us. This is a virtual program. But it includes virtual direct appointments, and we use endocrinologists, cardiologists, obviously obesity specialists, internists, but we also use community health workers and health coaches and patient coordinators with the understanding that patients open up more to them and are really able to talk about their own personal journey in the ways that we're able to help. You'll see some more data that I'll present on the following slide, but just on this slide, a lot of people are on medications that were prescribed that do not follow evidence-based guidelines. Some people are on medications that are obesogenic. The expertise in being able to tailor treatments is what we're really trying to do. NPS scores are important. We've got an NPS score of 75. I'd say the NPS score for the people who work within our organization is just as important, and that's at 80, and really tells us that we're helping them get up every day and love coming to work, which is what we're trying to do. But the really main thing, I think, for all of the work that we all do as we improve outcomes, it's how do we use care and good quality care to lower cost. And so we have been able to lower pharmacy cost significantly and then have a real impact on total cost of care at 2 years. It's usually the length of time that you would see medical claims change. This is some great independent work done by other organizations, not just by us on this. The key comes back to adherence. We really focus on it, and we really try to get people to use not just our app, but our remote monitoring devices. And I would say in everything that you've heard me talk about today, expect that we're using AIs to help our clinicians decrease administrative burden. We're using AI to help patients really get a personalized journey for them. And we're using AI in the way we look at our data analytics. It is embedded throughout our organization. There is an independent Milliman study that was done with Outflight Health, done in partnership with the PBM and looking at data. And that data showed a significant cost savings, even when you had GLP-1s within your formulary, coming back to following evidence-based guidelines, but more importantly, because we're treating not one condition, but all four, we're really able to have a significant impact on cost and in outcomes locally. I'd say the other thing that we do is we partner with the rest of your care team. We're on an electronic medical record. We're on Athena, and I'd say we probably do about 180 referrals back in per customer per month, really helping people not only look at what we do, but how we should be integrated within the healthcare ecosystem. We're proud of the stage 4A health value staging that we have within the Capital Impact Council. And we're continuing to do independent investments. These areas are changing dramatically. Cardio, kidney, metabolic is an area that we, I think, in this country can do really great at, and we're thrilled to be able to participate.
Cheryl, thanks for that really engaging presentation on a very important population health issue. As you said, you all have published some independent analyses of impact. We're now going to turn to another example with more of that. And by the way, thanks to everyone who's putting questions in the Q&A box. We're, I think, getting to some of those, at least in part, in the course of this discussion as it goes forward, but we are going to try to save a bit of time to work in even more. And in good timing with Rick's question I just posted, I'd like to turn to now to Alex Albert to talk about the application in the context of TPG's investment in FoodSmart, which is, Alex, a pretty mature company, but one where if you think about sort of gold standard or kind of high level evidence quality, independent randomized studies are what we often aspire to, and we look forward to hearing your experience in applying the evidence framework in this context.
Yeah, thanks, Mark. Happy to do so. And thanks, everybody, for taking the time. I'll say, obviously, all of us are passionate about healthcare investing. We're trying to do so in a way that provides demonstrable ways that private capital is having a positive impact on patient care, particularly in underserved populations, of which FoodSmart's focused on. And I'll just thematically say, we're all aware of the increased demand and spend on healthcare with increasing funding constraints. So regular priorities change, their shifting landscape. And what we have found and we love about this framework we've developed, and then certainly what FoodSmart's been able to demonstrate, is we can align our investing approach with real ways to show how these solutions are being needed in a very long-term secular way. So FoodSmart's just a really interesting company that our firm invested in through partnership with the founders and the management team. I mean, at its core, it's a platform that helps manage chronic conditions to support sustained behavioral change and improve core biometrics, whether it's heart disease, diabetes, cancer, digestive disorders. And why did we start there? Why are they addressing it? It's obviously fundamentally to improve patient lives, the health, well-being, and lives of patients, healthier, better lifestyles. But it, of course, also is to prevent and address that long tail of the high cost of care that result of not addressed through active interventions, particularly in sometimes largely underserved populations who don't get the focus or the intervention that would allow for better outcomes and lower total costs of the system. So I'd say there are four key pillars that FoodSmart specifically focuses on, and that we, as TPG, were excited to invest and partner with them to help expand, accelerate, and increase the breadth and reach of the services they provide. It's around personalized nutrition counseling, whether it's using one-on-one virtual or phone-based sessions with registered dietitians. We can start to create some tailored health plans. Certainly, we built on app-based tools, whether it's meals, chef-inspired recipes, some cases food delivery, and then also some of the things that can be a real constraint. Tools for comparing grocery prices, finding those discounts, assisting with SNAP enrollment, and then ultimately services on coverage. How do we make sure that we have the right relationships with Medicaid, Medicare Advantage, various other employer-sponsored health plans? So you can have a great model that's doing great things, but unless you can combine the access to the patients, the education, the direct intervention, and then ultimately the coverage, putting all those together is what ultimately allows the ecosystem of this company to then be in a position, to Mark mentioned, to measure, track, and monitor over time in a very rigorous way the positive impact that this type of a program can have, not just on the patients, but on the total funding and the downstream cost of care. And on this next page, which is if you guys don't mind going for one, I won't go through all the health value key performance indicators, but to Mark's point, this one is pretty progressed and quite rigorous in how we've identified, tracked, and measured some of the key KPIs and have been able to show just meaningful improvement in quality of life, cost of care, average PMPM costs that we're saving for a variety of the different payers that we partner with. But what I found most valuable, which I wanted to highlight in this webinar today, is it's one thing to say it, it's another to do the work and adhere to the framework to prove it. And obviously, it helps validate, I think, the impact of the model, which helps drive support and it helps drive certainly performance of the company. But what we have found the positive cycle, the loop, is it allows us to advance and evolve the business model and the approach to the most effective ways to address the goals of the company and the mission for us as investors. So by having a framework in place, proving out the benefits, we can then readjust to make sure that we are actively evolving the business model to get the best outcomes on the back end. And that's been, I think, for us, obviously in partnership with Mark and the Duke Margolis Institute, but as investors, it allows us to make real-time active decisions in business models that are mission-oriented, we have a real belief in, to continue to show, demonstrate, and help the patients align with the total cost of the healthcare ecosystem. So it's been very powerful as a result. Mark, maybe I'll go back to you.
Yeah, great. Thanks. And this has been, I think, very helpful ways of illustrating what exactly the framework means and how, as a company progresses with an intentional strategy, like you've heard in all of these examples, it's possible to get to a more comprehensive, high level of evidence. I do want to turn to, we're running a little tight on time. I do want to turn to how you make this more routine and systematic in other applications, but there have been a few questions. Maybe, Cheryl, I could ask you to help lead off on this one about, we've talked about a range of applications from early stage venture investment all the way up to private equity level. There have been a lot of questions, or some questions raised in our Q&A and more broadly in the public, particularly around private investment in ownership of healthcare organizations, whether it's for people with long-term disabilities or other types of institutions or healthcare delivery activities. Could you say a little bit about what we are about how this framework might apply in those cases as we keep working on expanding it?
Yeah, thank you, Mark. And I would just say I think everyone on the call is aware, many health systems have their own venture fund where they're also investing. So the need for innovation and bringing new solutions forward, it's not in one pocket, if you will, within healthcare. It's how do we do it most effectively? And that's really what we're focused on. I think when we look at the partnerships that health systems form or other existing healthcare organizations form, we're actually saying as they go in and partner with health systems should look at the health value work that an investor has completed, should make sure that they are aligned in the outcomes that they're looking for. There have been, again, I don't think any of us here are naive to say that there have not been bad examples. We're actually trying to say, how do you make it better from where we are today? And how do we set up that infrastructure to allow that positive work to occur? Usually, if for all of you who invest, you're probably aware, even if it's an entrepreneur, not even a health system, they usually will say, here's the problem, and here is how good quality care would look like, and how do we get there? Then you lay out the timeline and some of the metrics that you would go at along the way. But I want to say this because I think sometimes we don't say some of the difficult things. To achieve health value, you have to achieve financial sustainability. Else it goes away. And so one of the things that we're trying to do is ensure that we're embedding that health value into financial stability. The two are really needed. So Mark, that's how I would answer that. Hopefully
Yeah, I
that.
mean, this is, as we've heard, that the relevant outcomes in a particular context depend on that context. This is meant to be a framework that can be applied in a range of different contexts. As you have heard, I think some people have asked, our primary audience in this work to date has been the investment community and their potential partners like health systems in applying the framework in their context. We are very committed to fleshing out how this approach can work in additional contexts, including in areas of ownership, where there are some very important value measurable aspects of value in terms of access to care, patient experience, outcomes, and even measures related to impact on care capabilities in the community. So we look forward to continuing to build this work out. And in that spirit, I'd like to turn to our next panel. Very pleased to have Caroline Pearson and Kate Davidson with us today. So, we've talked about the goal of making this more routine and meaningful in the private investment context directly. Obviously, there is a lot of work going on to try to develop more objective, timely, and meaningful evidence to help advance the goals of healthcare reform. And we want to turn now to how this health value evidence quality framework can be potentially applied, scaled, improved, generalized more effectively in driving evidence-based reforms in our healthcare system and helping to assure that the private investment that takes place is having the maximum impact, whether that's early opportunities to help modify and improve private investment models and companies, or getting that very strong, high-grade evidence confirmatory of benefits and impact as these investments scale up. Kate Davidson was formerly the director of the Learning and Diffusion Group at the CMS Innovation Center. We're now very glad to have her with us at Duke Margolis as our area lead for strategic partnerships for healthcare transformation. Thanks for being with us. Caroline Pearson is the executive director of the Peterson Health Technology Institute, where she leads efforts to do independent evaluations of the clinical and economic impact of digital health solutions, where, as everyone knows, and we've seen in some of the examples today, there is a lot of private investment going on. We've been very lucky to be able to engage with Caroline with feedback as this work has developed, and we're hoping through further collaborations building on this recently released evidence quality framework that we can make even more progress. So both of you have extensive experience in advancing the development and use of better evidence to inform healthcare reform. Caroline, as I just mentioned, you've done a lot of work around independent assessment of evidence on the value impact of companies that are using digital health and AI to try to improve the value of care. Kate at the Innovation Center. The Innovation Center is very committed to evaluations of healthcare reforms and has tried to advance rapid learning to help inform the decisions of healthcare organizations that are trying to deliver care better, including through how they partner with private companies to achieve healthcare value goals. Maybe we could start out with a question for each of you on this. Caroline, maybe you first, as a third-party independent evaluator. What kind of steps do you think make evidence generation easier and could make it more routine in order to help accomplish the Peterson Health Technology Institute's goal, which is driving investment and driving healthcare in the direction of really contributing to better value?
Well, Mark, thanks for having me. And I want to commend the entire CIC team on this excellent work. I mean, I think it's really our shared goal. We all understand that We are trying to develop technology solutions that deliver for patients, that can support our access goals, our outcome ambitions, and can start to reduce healthcare spending. We come to our work really with the same goals that you do, but really focused on a different audience. So, we built our organization in response to employers, health plans, and health systems who said there's such a growth in the digital health space, and we're having trouble figuring out what works and what's worth it, to make sure that we are putting our resources into solutions that are going to deliver the most benefits to our members. And, but we have always understood that investors play a really critical role in helping ensure that companies are doing the work to develop that evidence, right? You have finite resources. You've got to make hard trade-offs between sales and marketing and product innovation, and evidence generation often falls by the wayside. And so I'm thrilled to see this emphasis on evidence so that we can continue to progress. When we do our work, we tend to focus, I think in your vernacular, we love like 4B in terms of evidence quality, right? We love to have comparative evidence, independently validated when possible, but you can't get there overnight. And so I think what's most important about the framework is this recognition that companies need an on-ramp, right, as part of their company development. And so it starts with really putting clinical outcomes at the center of what we're trying to build and staying focused on that, not just on growth, and then continuing to develop and test that as we go. So I think it's really about priorities. I think, for instance, I talked to a company recently. They had done a rigorous budget impact analysis with their own data. They would have been like stage 3, and they were convinced they did a great job. And I said, look, your methods look really sound and you're committed to transparency. And also, until we've had somebody independent in that data, it's hard to prove. And they took the hard step of sending all of their data to a researcher who thankfully came up with really similar results, but it increased the credibility. And so I think it's that commitment to building on what works and continuing to prove it with stronger and stronger evidence at every turn of company growth.
Have you seen good examples? And again, that the part of the purpose here is to make these better known within the investment community, but the outside pressure from and guidance from independent evaluators, hopefully, as you said, help everybody do this better. Have you had opportunities to connect with companies at an earlier stage to help them get moving down that path? And is that an area where there might be some further opportunities to help spread and increase the impact of and increase the development of meaningful evidence generation here?
I do think that's important. Early stage companies often don't know where to begin. And often, surprisingly, they don't necessarily know what their customers want most, right? There's lots of important things that you could try to measure against. And so am I choosing patient satisfaction measures? Am I choosing, one clinical outcome or another? And so I think one of the things we've done is create some process and some recommendations about by clinical area, which outcomes do we think are the highest priority and should be primary? But also, creating forums to connect companies to health plans and employers who are thinking about this every day so they can have those conversations to say, what would be compelling to you? And so it's nice to be able to facilitate those discussions to really focus that evidence generation process and make sure it's as efficient as possible.
Yeah, it does seem like there's some real synergies there. And I have to say, as we've gone around trying to get this framework developed and out there, a lot of companies are, as you said, they're busy with other things. They've got limited resources. They don't see sort of the easiest pathway, or don't see how important it is if they're really going to scale successfully. And conversely, on the purchaser side, the employers, the health plans, the healthcare organizations that might take advantage of this, obviously, the more they're getting good evidence and information to drive their decisions, that seems reinforcing too. And that brings me to asking a question of Kate. So in your work, which has been involved a lot of the Innovation Center initiatives that have this goal of trying to drive care delivery and the investment needed to support new care models into new directions. Big emphasis on not just the formal evaluations that can take multiple years, but I think trying to learn along the way about what's working and as your kind of key customers, most important is your beneficiaries, but obviously helping the healthcare providers, the health plans, and Medicare make informed decisions about how to improve care. That's important too. Could you talk a little bit about how this framework could be helpful for informing and supporting those important goals at CMS and in across other public sector purchasers of healthcare?
Yeah, thank you, Mark. I think I just want to first just underscore something that Cheryl mentioned at the top, and then I think Caroline also mentioned in her remarks, which is that there really is alignment across the goals in the private and public sector to reduce costs to the system and to improving outcomes for patient populations. But the data, as you mentioned, is really central to achieving that, both through new evidence generation to help us think critically about what and how we can scale innovations. And that the private sector is really much more nimble and flexible to be able to accelerate that evidence generation so we can think about how we use the public sector and government to support scale and spread. But I think I would also just mention here that it's important to also recognize that there are risks with that. And I think that's why the evidence generation and the rapid evidence generation is so important. We have a really fragmented healthcare system. And so when there's a lot of innovation happening all at once, especially in the consolidated area, there's a lot of questions about what works, what rises to the top, about what is the highest quality product. And so I think through this development or data collection and having a lot of transparency in the private sector, we can think about ways that the public sector can reinforce high quality programs. And so I would just want to reiterate one other thing, which is our healthcare system really works best when we have bidirectional learning between the private sector and the public sector. So the public sector, at least from my perspective, oftentimes learns about what the biggest problems are in healthcare by looking to where the private sector is going and where there's a need for innovation. And so a couple of concrete examples that I can think of at my time at the Innovation Center are two programs. There's kind of two ways that the Innovation Center tests payment models, or two programs in which we test Innovation Center models. One is in Medicaid, and the other one is in Medicare. And in Medicaid, oftentimes CMI leverages cooperative agreements to seed funding to states so that they can leverage their own authorities, which are oftentimes waivers, so they can test their own demonstrations and develop their own payment models. So INC is a good example of a model that will be ending soon, where states were really charged with trying to test new payment models that were going to improve care coordination for children with complex social and medical conditions. And states leveraged these funds to develop payment models, and they often use their waiver authority or managed care contracts to help them get further upstream and prevent further complications for that population. So if states found that they were effective in doing that, they can use some of the levers that they discovered there to spread and scale components of their care delivery and payment models through like a state plan amendment, for example. And on the Medicare side of the house at CMMI, we test payment models directly with Medicare providers. Folks are probably very familiar with a new model called Access that was recently released. And I think it's a great example here. CMMI saw a ton of innovation that was happening in the wellness spaces, but there just were too many barriers, regulatory barriers for technology companies to scale in Medicare. So CMMI developed a model, which is 10 years long, by the way. So there's lots of opportunity for rapid learning across that 10-year lifespan of that model to pay differently that was focusing on patient outcomes to test technology solutions in 3 specialty care spaces. So if that model proves to be effective, they will scale it into permanent Medicare programs. And finally, it's important because with regard to payment, we often see that commercial plans are following suit from the public sector. So you can really see this bidirectional learning that's happening from the private sector to the public sector back to the private sector, and then overall scaling across the system.
Great, thanks. And maybe just keeping with the access model that you mentioned. So for, as you said, this is a new type of payment in Medicare for companies essentially that are trying to help with preventing chronic diseases. I think Flight Health, for example, may be a participant in that program. I don't want to reveal any confidential information. This is still all in process, but I know Cheryl publicly has talked about this being a potentially important opportunity. But CMS there is paying in a different way. They're paying based on tracking a number of outcome measures essentially that matter for patients. In the case of cardiometabolic disease, it's BMI, it's blood pressure objectively measured, it's lab test results on lipid levels and kidney function. So that and improvements in those metrics is tied to payment. That seems like a good driver for encouraging companies to collect the kind of information, and when they're at those earlier stages, make sure they're working out that they can make a difference there. But maybe I could ask Caroline and then Kate. That's within the Medicare program. As you just said, we have a fragmented system. Do you see ways that sort of a public-private effort or a private effort combined with a public effort could help generate that kind of evidence faster I think employers want to know the same kinds of answers that CMS would like to know for its beneficiaries, for their own employees and dependents. Caroline?
Well, we have been working on the commercial side of the house and have seen just tremendous alignment with what the Access program laid out in terms of health plans and employers really wanting to pay for clinical outcomes. And feel confident about the outcomes that the solutions are delivering. So, it's not just Medicare. The commercial market has been focused on how to make those contracts easier. We did a big project over the course of a year to launch a series of toolkits to try to help ease that contracting burden. And you saw a bunch of the health plans that announced when the Access model came out that they actually were going to apply similar outcomes-based performance-based payments in multiple markets. So it's clear that that's where the demand is, and it creates a virtuous cycle. On the one hand, as you said, Mark, companies that want to be able to play in this space are going to increasingly need to know that they can deliver those outcomes, because it will be essential for their business model and to understand what kind of risk they're taking on in these contracts. So that early stage evidence generation becomes really necessary for digital health and health tech companies. But it also generates better evidence, right? The more we have outcomes-based contracting, the more evidence we are producing about how these solutions work at scale and for different subpopulations. So it's not just one company trying to fund a small study. You now have data coming out of the Medicare program, out of traditional Medicare, about the performance of all of these solutions. And that really enables much more sophisticated analysis in the future. So I think we're getting to the place where we're going to start to have a much richer evidence environment in both commercial, Medicare, and Medicaid.
And Kate, as CMS implements its models, it seems like partnerships with investors in trying to promote the availability of these kinds of data there too would be helpful. CMS does have access to some data, as you mentioned. They're going to track like claims utilization and impacts on things like potentially avoidable hospitalizations and so forth. But as you heard from many of the companies involved in this effort, these companies have potentially a lot more data from their closer relationships with the healthcare organizations, the hospitals, the health systems, the health plans, the providers involved on different subgroups of patients, those that might have particular kinds of challenges. So any further comments on how to leverage those opportunities as this work moves forward?
Yeah, I think that anytime you see the Innovation Center coming out with a 10-year model, you can anticipate that there's going to be opportunity to innovate and to iterate over the course of the life cycle of that model. And so I think that gives a couple of different opportunities. One is to think about how you create those feedback loops across the private sector into the public sector, really providing both qualitative data as well as quantitative data about the ways that the model is designed, that either create barriers or create opportunities, and more importantly, how they're connected to potential cost savings and improvements in quality for the patient populations that they're targeting. I also think, getting back to the fragmentation question, over the course of a 10-year life cycle of a model, there's an opportunity to do alignment efforts with other payers across the commercial sector. And so, you saw that many people probably saw that there was a payer pledge for folks that were interested in working alongside with CMS on models for their own product lines as well. And I would say that alignment takes time, and alignment takes a lot of data, communication, partnership efforts. And so this idea that over the course of a 10-year time period, you could see less fragmentation if the private and public sectors are working together to align around the things that are most important to patients and providers.
Well, thanks. I really appreciate both of you joining us. Clearly, some important work has been done, but so many more opportunities, as Caroline was saying, to build on this momentum, to get to more systematic and meaningful evidence faster, and make this more routine and applied in a broader range of areas where private investment is going on and could potentially be helpful, but definitely raises some concerns as it applies in healthcare reform. So thank you all very much for that. I do want to try to we've answered a number of the excellent questions, many of them that have come up in the Q&A along the way. So for all of our panelists who are still with us, if you come back on the screen, and I'm going to try and get through some of these that we haven't touched on already. I would like to, several of these questions are about sort of similar work in areas that we've already covered. So food as medicine is a broad area. Alex, you all have done some, as we talked about, some randomized trial evidence in that context, if you're still available. Question is, do other companies, maybe others could answer this too, but do other companies in that same space who haven't done exactly what FoodSmart has done, can they leverage that experience? And I guess the answer is to some extent probably yes, but boy, when you get into the reality of trying to improve care in different contexts or different kinds of interventions, is kind of reminded that the easier you can make it to generate good evidence in those particular real world applications, the better, because healthcare is complicated, and we just there's so many opportunities to keep learning about what works best. Alex, any comments you'd like to add on that, or others?
I really love that question, because that gets at why not we as mission-oriented healthcare investors do what we do, but why we're involved in this initiative is because we think this is a good thing for everybody to try to do. So if there's like an example setting component to it, I mean, obviously, and Cheryl's made this point, I mean, we need a sustainable financial business model in order to ultimately have a business that can provide this access and this impact and this quality. So our job is obviously private capital investors to try to identify those, help enhance, grow, and the success of the company that ultimately has a success for the healthcare ecosystem. And so the whole point of getting involved in this initiative is to try to, I mean, we're kind of learning as we go too. I mean, you don't just start out with randomized clinical trials, you kind of build up to it. But by providing a framework that we can show we think has real impact, positive in the ecosystem, positive to our investments, and then help spread that so that others can learn, adopt, and evolve. I mean, that's the whole point. I mean, we're all trying to accomplish the same thing as healthcare investors. And so the more we can get the message out to help others do so, that's a big win for everybody.
Great. Thank you. And now I'm going to try to combine two questions. One was, or several were essentially about, well, can this framework, you talked about applying this in the for-profit investor context, can this framework be applied in the nonprofit context where nonprofit organizations are very much trying to improve care? I'm going to combine that with another question, which is about how several of you mentioned gains and returns that might happen over several years. Or I think in Amir's case, for an early stage company, it may be more years than that before there's a clear path to return on investment. And most of the things, the kinds of reforms that are needed in healthcare, are very hard to do and show returns on in the short term. So two aspects of this question. One, if you look at many nonprofits today, they are struggling. They're able to maintain revenues maybe ahead of expenses, but it doesn't necessarily, especially if they're smaller, provide a good avenue towards setting aside funds that to make investments that may take some years to implement effectively and improve those financial returns, or to and make it possible to succeed in value-based or outcome-oriented payment models. Suzanne, I know several of you have been working with nonprofit organizations, and I think Cheryl mentioned that some nonprofit hospital systems, other organizations have private investment funds that they work with. Can you all talk about how there is kind of a partnership between, or potential partnerships between nonprofit organizations and for-profit entities that can help generate that capital needed to support transformative models of care? Suzanne, I'm kind of picking on you since I know that's part of your model design, but that applies to many of the investors here.
Yeah. So the four plans that we work with in the healthcare space, they're all nonprofits. So that just by design is a framework that we're working in. And then within their healthcare ecosystem, they're working with different clinics, different health systems, different providers who would fit that for community care as well. And so an important piece that we think about is, yes, where are those financial returns? But I mentioned too that strategic engagement, because that is very important, particularly in nonprofit. You do want to watch the financial levers. You do want to stay within the framework of impact, both at a provider and even a nonprofit payer level. But you might have some broader degrees of freedom within that, which can be beneficial. But I think overall, the same parameters are important in those markets that they are in regular markets. Like, are you actually providing better care and outcomes? I think you just may have different ways to do that. And for us, we're able to embed a bit more in the plan side that is providing some of the care and the care management that then flows down on the provider side too, that is really touching members first for those plans. So it's the same parameters, but I would say, because I saw this question come through, we did look at the nonprofit sector first from even a non-healthcare point of view to say, what are they measuring? What are they looking at? What are the gauges that are important there that we might be able to pull into the work that we're doing? And it's informed a lot of that work that we've done with our portfolio companies to measure that, as well as the Margolis work.
Great. And also this point, maybe for thanks you, Stan. Great to hear how this model is working with nonprofits. And there are a lot of other types of nonprofits out there that similarly could use the investment help if it's really aligned with their goals. Some of the other questions were around, well, is this a way to enable investments that may not pay off for 2 or 3 or 4 years or longer, which can be hard for nonprofits to manage on their own? Anybody want to comment on that? I think Amir, you mentioned this earlier. I think a lot of the organizations that your populations work with are served by, or are federally qualified health centers, other entities served under Medicaid that are nonprofit and kind of struggling with resources for transforming care.
Yeah, thank you, Mark. I think a few reflections. Part of the reason I think private capital exists in this space is we're trying to do things that are very early on and very risky that may or may not have an ultimate financial ROI. And so when looking at companies to invest in, and let's say they're selling into health benefits leaders, as Caroline was describing, or into health plans, like the plans that Suzanne represents, you want to show them as soon as possible that this thing could work and that there is ROI. It's why the HVROI model is, I think, so extremely helpful, because it could be a tool that startups can show potential payers, hey, we're following this path, hang in with us. I spoke to in-year results for MI Health and serious mental illness. That's nice too, because health plans often have churn in their patient populations, and they're like, oh, this is going to save money 4 years from now. Huh, that's interesting. So in-year ROI can be important. So for early stage startups like as the ones we invest in, having good rigorous measurements, or at least a roadmap of how they're going to do good rigorous measurements, like the framework we've talked about today, I think are really important to help them sell into benefits leaders, into health plans, and to the extent that they could show in-year returns, those purchasers can have higher belief in hanging on for the multi-year journey that it often takes a startup to reach kind of viability.
Yeah, it is. This is work that cannot be accomplished overnight, but hopefully through the steps we're describing here, it can be accomplished faster and with more certainty. I want to thank all of you for taking the time, and I know we just have a minute left. And we did not get through all the questions. They're great questions and good advice for us on our next steps. If we go to the next slide, put that back up, take Amir off the screen. We do want to look ahead. And as you've heard, while we think there have been some important applications of this framework already and opportunities for growth, there is still a long way to go in terms of having the kinds of clear evidence readily available that we'd like to see. Some of the questions related to, can this apply to companies doing investments in other countries? Are there ways to pitch? We view this as our primary purpose to date has been finding ways to bring the investment community together around what are the best practices in different areas of investment that are potentially critical to improving health, improving access, and lowering healthcare costs, and how can we spread those best practices. As you can see on this slide, now that we have these frameworks out and some early examples, we're looking for more investors who are willing to come in and commit to the framework, commit to co-developing it with us and with partners, the independent evaluators, the organizations that are trying to support the development of better, independent, credible evidence on the best ways to improve care, lower costs, and avoid, create guardrails and help avoid investments that don't. That's not a sustainable way to improve our healthcare system, and we do need a lot of improvements right now. So here are some extensions that we're working on through our Capital Impact Council Health Value Hub to make this more of a hub to bring together these perspectives and hopefully accelerate progress. So we encourage you, if you think you might fit into one of these goals, a potential user of some of this evidence, ideas on how to make it better in particular applications or new areas that we haven't gone into more deeply yet. We talked about ownership issues earlier. We do want to hear from you. This is an ongoing, growing, collaborative hub project from here on out. So thank you all for joining us today. One more slide on another upcoming Duke Margolis event that we'd like everyone to think about joining either in person in Washington, D.C. or virtually. May 15th. Hard to believe, but the Duke Margolis Institute has been around for about a decade. So instead of looking back for 10 years, we're going to look forward. Where is healthcare going? And some of these issues related to how to ensure that investment that takes place is having the maximum impact on improving care will be one of many of the topics that we'll be considering there. In the meantime, thank you very much for joining us today. Thank you for the frank and very helpful as we continue to extend this work, comments and questions. And we look forward to working with many of you in future Duke Margolis events, activities, and webinars like this one. Please take care.